So how long do opiate withdrawal symptoms last? After a short-acting opiate like heroin or hydrocodone, immediate release is stopped. Withdrawal symptoms persist for, how many people say A, 1 to 4 days? 1 to 2 days, sorry. How many people say B, 3 to 5 days? That's it, 3 to 5 days. That's with a short-acting opiate. And then if you have a longer-acting opiate, something like methadone or something like oxycodone and an extended release, how many people say 3 to 5 days? How many say 7 to 10? How about 10 to 14 days? Yeah, so that's the answer, 10 to 14 days. And each person is different. Metabolism of methadone varies patient to patient, but it can really stick around in your system quite a while. So patients can be legitimately complaining of withdrawal problems for quite a while afterwards. So one of our mainstays of treatment here is alpha-adrenergic agonists, but overall, if you look at the statistics, they don't work as well as methadone as buprenorphine might. So what we commonly use is clonidine. It comes as catapress in oral or patch form as well. And typically, even today, it's off-label for use, but somewhere 0.1, 0.3 milligrams, 3 or 4 times a day. And the typical symptoms, the GI symptoms, the sweating, anxiety, irritability, are all helped quite a bit. Problems are heart rate goes down, blood pressure goes down, patients fall out, not so good. Patients may be sedated. Sometimes they like that, sometimes not so much. But it's cheap. The medical letter reviewed this last month, and maybe about $1 a day. There is a new drug, Lofexidine or Lucemyra, and I say it's new because the FDA just approved it this year. It's another alpha-2 blocker for opiate withdrawal symptoms for people who stop abruptly. England, it's been available for over 25 years, and it's a weird dosing. Take 0.18 milligrams, but take 3 at a time, maybe even 4 at a time in some studies, and you take it every 6 hours for somewhere up to 2 weeks. Again, it depends what are you withdrawing from, how long are you experiencing side effects. Less hypotension than clonidine, but we have to worry it's metabolized through the 2D6 enzyme system, and QTc prolongation is definitely an issue with this drug. And even though Blue Cross is a pretty conservative company in formulary, they approved it on formulary because they are wanting to do something to really help combat, the opioid epidemic that we have here. But the cost is ridiculous. This is for about a 2-week course of treatment or over $100 a day. So we can go on label with this, or we can go off label with clonidine, and the cost savings is quite significant. But Lofexidine is out there and available potentially. Buprenorphine, also used for opiate withdrawal symptoms. Had a patient who was admitted last Thursday or Friday, and he was really agitated, causing a lot of difficulty, and he definitely had a history of first prescription pain medicine abuse, then it switched to heroin. He was giving the nurses a lot of problems. The hospitalist put him on buprenorphine, happened to be an 8 milligram dose that he was given. Oh my gosh, he was a different person 2 hours later, and calm, cooperative with the nurses, changed altogether. So buprenorphine, Schedule 3 rather than Schedule 2, as many of our opiates are. It's a partial agonist of the mu-opioid receptors and a kappa receptor antagonist. And we can use it by itself, or obviously we can use it with naloxone. And the deal there is if you have a sublingual film, or if you have a tablet and swallow it, naloxone doesn't really do anything. But if you try to crush it and snort it, naloxone is active and blocks your high. If you try to inject it, likewise, the naloxone becomes physiologically active. So one thing, since it's a partial agonist at the mu receptors, we could put people into withdrawal by putting them on buprenorphine. So you're supposed to wait until they have mild to moderate withdrawal symptoms. So the COWS stands for the Clinical Opiate Withdrawal Syndrome score. And you have to be careful using this. I think it's 11 or so items. And I did the COWS score on myself this morning. After I got back from running, there was water streaming down my face. That's like tears or lacrimation. I was sweating, and my heart rate was up. So that would give me a COWS score of at least 11 or 12 on that scale. I've never taken an opiate in my life, though. So I know I wasn't in withdrawal. But if patients are truly withdrawing from opiates, you can look at this score, and it's somewhat objective, a little bit subjective, and you want to wait to start a drug like buprenorphine until there's some withdrawal that they're going through. So typically wait at least 12 hours after the last dose of a short-acting opiate. And typically start 2 or 4. You can go up to 8 to 16 milligrams until the withdrawal symptoms are better. And generally, compared to methadone, methadone has more cardiac concerns, more QT prolongation, more risk of respiratory depression. Typically, we hit a ceiling with buprenorphine, and I don't want to say it's foolproof safe. If you mix buprenorphine with enough alcohol, with benzos, you can have people dying. It's not 100% safe, but probably safer than methadone. And for opiate withdrawal, medical letter reviewed this and said this is treatment of choice according to our standards. Overdoses of opiates. Ideally, we would like to be intervening before patients crash into our ER, but everyone is affected. Public health, families, police, first responders are seeing this all the time. So naloxone is available IV, but most patients don't come with a hep lock. A lot of them are not easy to get IVs on if they're shut down. Intranasal is the route that we're looking at using it for first responders. And the problem is people are using stronger stuff, especially if they have a fentanyl, carfentanil laced product. It may take a lot more than your first or even second injection of naloxone to bring somebody around. But if you're pretty sure that this is the mechanism by which this patient is so obtunded, you keep giving it. And there's a debate, do we bring these people to the ER or do we just say, oh, you woke up, you're good? Well, the half-life of naloxone, relatively short. As we've seen, the half-life of opiates is much longer. So, I think these people need medical attention outside of just a squirt up the nostril, somewhere out in the field. A recent study in Annals of Internal Medicine definitely says that naloxone can save lives. Higher concentration dose is probably better than the low concentration. It can be given IM and obviously IV. Blue Cross, in their infinite wisdom, decided if you're going to get a prescription, 2 per month. I think they're partly worried about diversion because there may be some street value that people would sell it, share it, whatever. And hopefully, if you're needing more than 2 a month, you're getting treatment. We don't want to just have people resuscitated with naloxone and say, good, back to your ways. This should be a sign that something medically dangerous, psychologically dangerous is happening. You need help. It's not just enough to bring you around. A public health question is, who should have access to naloxone? Just our patients for whom we write a prescription? Or should I be able to walk into Walgreens this afternoon and say, I would like to buy, with my own money, 4 or 5 bottles because, my brother, my son, my father is an opiate addict. Or every patient who's on more than 100 milligrams of morphine or equivalents, should they get? Pick your number of what's an unsafe dose of morphine, but should naloxone be in those households? Probably so. Obviously, if you have known addicts, they ought to have somebody around them that has access to naloxone. But right now, it's typically not in this country available just on a over-the-counter basis. So there's MAT, which is called medication-assisted treatment. Another term is medication for addiction treatment, because what the CDC said in their guidelines is that medication for addiction treatment is really the primary therapy. It's great to go to a Narcotics Anonymous meeting. It's great to have counseling, but medication is really the primary treatment for people with opiate use disorder. And we detox people in hospital, in other settings, and the problem is after they're detoxed, at least half of them are relapsed within a month or 2 after they stop something like buprenorphine. They did a survey and said, okay, you guys who are entering treatment yet again for opiate problems, these were not first time around folks. If you got discharged and didn't get medically assisted treatment what happened? How soon did you relapse? A quarter of them was the same day they were discharged, about 2/3 within a month, and about 90% within a year. So, relapse without MAT seems to be the unfortunate standard of what is happening. Methadone is a Schedule II drug. It's a full mu opioid agonist, and the half-life is all over the place. 8 hours up to about 60 hours. It's lipophilic, so those of us with more adipose tissue, it may take longer to eventually get cleared. Comes in liquid forms, wafer forms, and pill forms. It's for once a day dosing. And typically you have to start at a low dose, less than 40 milligrams a day, and adjust in small increments. I review malpractice cases for SVMIC, and there was a big case where a psychiatrist and the inpatient facility were sued because the dose of methadone given to a patient had been ramped up really quite quickly. And I think it was on day 6, the patient was found dead, tragically. So methadone needs to be carefully titrated under experienced hands as opposed to, great, they say they want more, I'll just give them more. Not necessarily the thing to do. And if you've got a patient on methadone, what does it take to keep them opiate-free, meaning I'm not going to go back to injecting heroin? Typically doses that seem really high, 80 to 120 milligrams a day. And when they've done studies stratifying with dose, patients who are maybe just getting 50 milligrams a day, their dirty urine drug screens showing that they have relapsed to something like heroin, much higher if you're on low doses of methadone than if you are on higher doses of methadone. Once you're on it, typically people stay on it for at least a year, sometimes forever. But if you are going to taper it, don't stop abruptly. It's a slow taper, 10% or less every couple weeks or so. So again, something that can take a while to build up and even longer to taper off. Also, we can screw patients up. A lot of drugs that will inhibit or induce 3A4 are out there, same way with 2D6 inhibitors. So we can effectively raise the serum level of methadone by giving them or taking away certain drugs that affect liver enzymes. So be cautious and also check EKGs for QT intervals because so many of our drugs can prolong QT. Buprenorphine has been around since 2002, initially as a sublingual tablet and now also as the film strips. There's more recently been a subcutaneous once-a-month injection. There's also a 6-month implant of buprenorphine. I've never used or recommended those myself, but half-life is a little over a day for buprenorphine. And the fact that it can precipitate withdrawal, as I said earlier, means that we should wait a little while before starting this, whether it's for opiate withdrawal or opioid medication-assisted treatment. Typically up to 24 milligrams a day, and the cost around $300 a month. GoodRx.com gives you a coupon discount, so maybe it's about $4 a day. That may not be the price that's actually at a treatment program because there's other costs built in for monitoring, for counseling, for assessment, for dispensing. And also buprenorphine comes combined with Naloxone. A lot of us have heard of Suboxone, and so they have this combination. Typically, it's a 4-to-1 ratio of buprenorphine to Naloxone in various strengths. And different than methadone, you can dispense this out of your office, at a community hospital, out of a health department clinic, and even in a correctional facility. Many of our jails want nothing to do with buprenorphine or other opiates for understandable reasons. But in theory, you can get a license. You do have to be specifically trained. It's an 8-hour training program for physicians, but nurse practitioners, physicians' assistants, because of the shortage of trained providers, they can do 24 hours of training and also get approved to be buprenorphine providers. Year 1, you're limited. You can only do 30 patients per year. that gradually can go up if you document and show you know what you're doing to 100 patients a year, and then eventually you can apply for another waiver, 275 patients per year. But we have way too few providers, or some providers who are trained and licensed but don't necessarily actively make this part of their practice. So Naltrexone is a competitive mu opioid receptor antagonist. It's oral or it's IM, and they've looked at it lasts for 1, 2, or 3 days, depending on what dose of naltrexone we use orally. But the problem is opiate addicts don't necessarily do well in randomized placebo-controlled studies. Why? They don't take it. They decide, I'm not so thrilled with this. I'm missing my drug of choice. And so non-adherence is a big problem. And that's where they've come up with this once a month. It's a deep gluteal IM injection, happens to be 380 milligrams. And the problem is you can't just give it day one of treatment. Have to make sure the opiates have washed out for a week or two, depending on what they've been using. The other problem, I don't think it's on my slide, is cost. The cost of this, the cheap price, according to GoodRx, is about $1,300 a month. The cash price, about $1,800 a month. And as much as that sounds exorbitantly expensive, what does it cost for people to rotate through our ER with overdoses? What does it cost in first responder bills? So it may actually be cost effective, even though this shot carries a very high price tag. First, to do no harm, my wife teaches Latin, and she said it's primum non cari. I would have never pronounced it that way. But we've all been told in medical school, primum non cari, we should not hurt people. And so a different perspective is the harm reduction model, and this looks at meeting people where they are and how can we help reduce the negative consequences of your use. It's respecting people, which is not easy to do. Some of these drug abusers are very difficult individuals to deal with, especially when they're intoxicated or withdrawing. They're not the most pleasant people. So how to treat them respectfully and say, okay, I know you've been, injecting heroin. How can I help you? Let's meet halfway. You may not want to stop totally, but at least can we get you to a point where you may be able to reduce your use, or the pre-contemplation state of thinking about getting help. So when I was out in California last month, I did something out of character. I went to the Ronald Reagan Presidential Library. I wasn't not a huge fan of his, but Nancy Reagan, his wife, was a champion of the Just Say No to Drugs movement. And abstinence only, that was one of her big things as First Lady. And so do we take that approach, or the sort of Nike ads, just do it, whatever you want, it's all okay. But the idea of harm reduction is meet people where they are at that moment, and also looking at abstinence is not the only goal. It would be ideal, we would all agree, but if patients will use less frequently, lesser amounts, and that could be a much better outcome for them and for their families. And using drugs safely, is something we look at here. Marijuana is a Schedule I unacceptable drug. And in Colorado, at least 13% of adults who are kind of your age, I'm pointing to the residents and med students, will use marijuana products, and it's totally legal. So, a big debate. Another huge controversy is around legal injection sites. There was just an article this year in Annals of Internal Medicine that looked at how do we stop overdose fatalities. So a supervised injection facility has been used in Holland and other European countries, and there's even some look at, starting this in Vancouver and big American cities, New York, Chicago, LA, experimenting with this. And the idea is this is the place where you can go, and another aspect of safety is testing. So what are you injecting? You think it's heroin, but is it laced with fentanyl or carfentanil? So to try to actually help people, and say, we want you to not kill yourself with this next injection. It also would have naloxone available, but ultimately these safe injection facilities seem to reduce overall mortality, overdoses that require ER visits, transmission of infectious diseases, and a lot of people will eventually come around with enough help, enough support, will say, okay, tell me a little bit about your treatment program, because maybe I'm tired of living this way. So there is a movement that safe injection facilities may be popping up. I don't think we're opening one here in Chattanooga anytime soon, though. One last area I want to turn to is the use of addictive medication for therapeutic purposes. Timothy Leary was a famous Harvard psychology professor who championed the use of LSD, and unfortunately somebody died in one of his experiments. He was drummed out of academia, but there's been a resurgence of interest and actually academic, evidence-based studies looking at all sorts of products. So ketamine, if you went to the American Psychiatric Association meetings this year, half the talks were about ketamine for treatment-resistant depression and also maybe for acute suicidal thoughts. So there have been a number of phase 3 studies. A new drug application for an intranasal form was submitted. If any of you read glossy magazines, there's an ad for a local ketamine clinic, not endorsing it by any means, but a family physician is offering Botox, spa aesthetic services, and also ketamine that can be infused. One of my patients said it was about $450 per injection, or infusion, sorry. Takes about an hour. So not sure that individual should be doing it, but it's out there, and it will likely be FDA approved in some form in the next couple years. There are dangers. There are drawbacks. It can make people crazy, but it is likely to be available in some way. LSD, bad trips are something that are common in lore, but looked at years ago for alcohol dependence, looked at more recently for treatment-resistant depression, psilocybin or magic mushrooms for PTSD, also for terminal cancer patients. And I'm not talking about just out there fly-by-night things. Johns Hopkins, Columbia, reputable institutions are studying these with grants. So it's not something that just clandestine labs are doing somewhere. One of my favorite authors is a guy named Michael Pollan, and he's written a book, How to Change Your Mind. It's just published this year. Michael Pollan is famous as a food writer, and he's got a famous 7-word diet plan. Eat food, mostly plants, not too much. So Michael Pollan has lately gotten interested in the whole role of various pharmaceutical and illicit products. So patients will be talking about these if you are open to asking them. What's available around here? Inpatient. Erlanger has its own behavioral health hospital now, and there's always Park Ridge Valley. Knox and Bend, I don't think, does addiction treatment. They typically will take people off substances. They're really not geared towards long-term treatment of people with addictive disorders. But lots of people there have dual diagnosis addictions. There are partial hospital programs or intensive outpatient programs, more like 6 hours a day, more like 3 hours a day. One thing I'd be cautious, I know at least one of the local inpatient treatment programs does not offer medication-assisted treatment for opiate patients. So if that's something you believe in and think is necessary, check out the program first. Is this an option at programs like that? There are various residential facilities. Over on Bell Avenue, Cadis built a 24-bed, I think, apartment building. It's sort of a long-term halfway house that folks can check into. 12-step meetings. The last two, Al-Anon, Nar-Anon, are for family members of alcoholics or narcotic abusers. And Celebrate Recovery is available at various local churches. You can look into all that. Locally, medication-assisted treatment is not always easy to access. Dr. Cable back there is director of Volunteer Comprehensive Treatment Center. That's on Rossville Avenue. If you ever drive past at 5:30 or 6 in the morning, long line out the door of people lining up to get their medication, whether that's methadone, buprenorphine. There's also Bradford, there's also Cadis. A huge area which we may be moving towards is we deal with detoxing an opiate addict, or we get them out of a coma. We'd like to detox them, and should we start medication-assisted treatment in the ER? There's some grants, some studies being done in Colorado, actually looking at starting there because it's a captive patient, and then getting the patient hooked in directly. It's all the links in our system that really seem to be a big problem. Erlanger has its own opioid use task force that Dr. Mahaffey is heading up. So looking at various areas, and ideally, how do we deal with different populations? If somebody's never been on opiates, how do we give them as little as possible for as short a time as possible, which is really different than chronic patients who are on over 100 morphine equivalents a day, or those who are already on MAT, and finally, people who are abusing substances. So wrapping up the key points, this is a brain disease, not weak will, not a personality disorder. And basically people will, as they've demonstrated with rats in studies, they will give up all sorts of food, water, shelter, relationships in order to get their substance of choice. And we make really poor decisions. We don't control our impulses well under the influence of addictive substances. Obviously prevalent, costly, and you all as primary care physicians are probably in one of the best positions, whether you're in an inpatient or outpatient setting, to identify at-risk patients and how can we get them towards some sort of intervention, some towards of help, but do it in a compassionate manner that actually respects someone, and you're much more likely to have that person come back. But ultimately, referral to treatment is really key. So let me stop there and see if any questions y'all have. Thank you.
Anybody have any questions?
Jeff.
There is reported a genetic predisposition, predilection, or addiction to alcohol.
Yes.
Is that a proven and utilized bit of information? Does it also relate to opioid use?
Yeah, so a question, if you didn't hear it, is we've seen that there's a genetic predisposition to alcohol use disorders. Is it true for opioid use disorders as well? And we can't exactly point to the gene, the chromosome that causes, but what we see a lot is particularly father to son genetic transmission. So if your paternal grandfather, if your father was an alcoholic, your risk is huge for becoming an alcoholic yourself, especially if you're male. With opioid use disorders, again, it seems to be partly genetic, and some of it is, how do you respond? So the first time my wife ever took an opiate after some minor surgery, she was crying, she was miserable, and not because of pain. She hated how it made her feel. But there are people who take an opiate and say, oh my gosh, this is like, speed, I feel so amazing. It's like, when can I have this again? So those patients are at greater risk, but we don't yet have a specific genetic test that says, okay, this patient sitting in front of me, are at such high risk, I can't prescribe an opiate, but we may be there one day.
A little bit of a late start this morning, so I'm sure Dr. Cohen will take the questions offline.
Okay, so come on up here if you have other questions.
You can write Naloxone for family members.
Oh, great. Okay.
And there is a good Samaritan law, so you won't be blamed if you use it on someone in the street. So he has made some steps towards
Great. Well, thank you.